Welcome to the Ocular Surface Academy podcast, TFOS DEWS 2 edition. Join us as we meet with the researchers behind this landmark international consensus. Each episode will feature practical clinical takeaways. Before we get to today's episode, here's a quick word from our sponsor.
Founded in 2011, Sight Sciences develops and commercializes intelligently designed and engineered ophthalmic medical devices that take into consideration the underlying causes of the world's most prevalent eye diseases, dry eye and glaucoma. Sight Sciences is pleased to support educational conversations through our exclusive sponsorship of Ocular Surface Academy, the TFOS DEWS 2 edition podcast. Visit us at sightsciences.com for more information.
Welcome your host and co-host for today's episode of the Ocular Surface Academy podcast, Dr. Scott Schachter and Dr. Christopher Starr.
So welcome everybody to Ocular Surface Academy TFOS DEWS 2 edition, running through the subcommittees. Today we have the pleasure of meeting with Fiona Stapleton, who was heading up the Epidemiology Committee, joined by Chris Starr of the Star in New York City. Appreciate you being here, both of you being here as well. I know it's tomorrow in Australia, I believe. So thank you all for being here. And so Fiona, epidemiology, which may not always be the most compelling subject for people to take on, but I read through the subcommittee and there's a lot of interesting information, range of prevalence, impact economically, personally, future directions, thoughts on how we can do things better. So why don't you share some of your experience as part of the subcommittee from TFOS DEWS 2?
Well, look, thank you so much for inviting me. It's a real honour to be invited to speak on this topic. So the subcommittee was a group of about 12 people who had been fairly active in looking at how common dry eye is, who gets it, what causes it, and what are some likely ways that we can think about targeting risk factors to look at treatment. So our goal was really to try and formulate the best evidence at that time to provide some information, as you say, on how common the disease is in terms of prevalence, how it changes over time, and what are some major risk factors or perhaps emerging risk factors that we can focus on. And part of that was looking at the impact of disease, the cost both to the society and to the individual, and to try and understand some of those things which might be going on in different cultural or racial groups as well, which might influence some of those parameters. So I think some of the findings that you kind of touched on there that were interesting, we were able to confirm some of the things that had been anticipated, I think, before this report in terms of Southeast Asian groups having a higher risk, but also understanding how both symptoms and signs change over time. So we were able to do a meta-analysis across all the studies, which means grouping them all together and looking for trends over time and to disaggregate what's happening with age and between men and women. So I think that was something that we were able to do because of the volume of the studies that have been published since the last report.
Well, I certainly commend you because it's looking through all the subcommittees and all the reports, I have to imagine that your subcommittee must have been one of the more challenging ones because the literature is just so all over the place. The studies of prevalence, there's so many variables. It's apples to oranges to bananas to pears to grapes. I mean, there are very few studies use the exact same parameters, the exact same questionnaire. And of course, geographically and societal issues and sex and gender, having so many issues that go into it and so many variables that make these studies so disparate that I'm sure you had your work cut out for you as a subcommittee, and it must have been fairly challenging. But that being said, I'll ask you, Fiona, as the world expert on ocular dry eye disease prevalence, what is the exact worldwide prevalence of dry eye disease? And one number, please.
Oh, now that's hard. That's really
I know, it's impossible. It's not known.
I've kind of given a range in the paper because we sort of slightly sat on the fence, I think, there. And I think we agreed as a subcommittee, we probably have somewhere like 5 to 10% that have more severe disease. And then we have a group that may be 30 or 40% that may have more mild to moderate disease. And I think, again, it depends on your definitions. And one of the things that we tried to do in that report was to agree on how to stratify the studies. So some studies have just looked at symptoms of disease. Some have looked at signs and symptoms, and some have looked at signs predominantly. So we were able to sort of stratify on those bases. So it really does depend on how you measure. And the other, I guess, confounding feature of signs-only disease, we've come across this term that's being used quite a lot in the literature now called non-obvious disease, which is sort of signs only. And if you look at that group, things like, for example, meibomian gland changes, you can see how they change with age, but you've really got to overlay that with when people are symptomatic. So I think that idea of focusing on a definition that has both signs and symptoms probably gives you the best, I guess, estimate of prevalence and where you can kind of intervene.
If you were to, do you happen to remember, the subcommittee agreed that prevalence ranges between 5 and 50% based on studies. Do you happen to remember the 5% study and the 50% study, and what was the most significant difference between those two?
So the 5% studies came from the large studies that were carried out in the US, the women's health and the physicians' health studies, so large-scale epidemiological studies. The 50% came from studies that were done in Asia that might have included looking at both signs and symptoms of disease. So again, this is perhaps coming back to that difference in how you define dry eye. You know, we've got this lovely definition, I think, from TFOS DEWS 2 now, but you also have to operationalize that when you look at a prevalent study. You have to take that definition and say, well, what does that mean? Someone who's symptomatic, well, are they symptomatic all the time? Are they, you know, you have to kind of work out how you operationalize a definition, and everybody's done that differently. So that's, I think, from a perspective of understanding the disease, if we think it's symptomatic and we've got signs, we need to capture that in a definition. So you can see the difference there between those large-scale prevalent studies that used, say, a questionnaire versus studies that have used a questionnaire and maybe certain findings, perhaps. So again, you've got those. That's, I think, most of the reason for that differential. And also we know that the Southeast Asian racial background is associated with somewhere between a 1.5 and 2 times higher risk, irrespective of which definition that you use.
Well, I know that part of the initiative of TFOS DEWS 2 was to kind of homogenize the world so that we're all kind of speaking the same language and categorizing the definition of dry eye the same, and that we all kind of follow the same definition, which I 100% agree with. And that's part of the reason why the committees were so internationally represented, to get the whole world on the same page. And one of the things that you said in your subcommittee was, well, you need a definition first, and then you can do prevalence studies based on that definition, which I totally agree with. And of course, TFOS DEWS 2 gave us, I thought, a fantastic definition of dry eye disease. But as I review that definition and think about how this definition will impact future studies of prevalence, I'm still not certain because the definition is kind of broad. It's not, there's no quantification in the definition. It's broad. You know, terms like etiologic factors and nerves and osmolarity and inflammation and symptoms. And do you feel that based on the TFOS DEWS 2 definition of dry eye disease, that with that definition going forward, we should be doing prevalence studies in different ways around the world so that we're all kind of homogenized and the data is apples to apples?
Yeah, I mean, I think I alluded to this with talking about that whole operationalizing the definition to sort of run it without sort of getting into, you know, my nerdy epidemiological side. You know, it is about taking that definition and saying, okay, well, if you've got symptoms, what does that mean? You know, in terms of the severity, the frequency, and in terms of the signs, you know, what degree of staining do you need? What level of osmolarity do you need? And so on. So that, I think, rolled then into the diagnosis report. And I think we've got some sensible cutoffs in that report that will help that whole question of measuring prevalence. And the other question, I think, is how we grade severity. You know, where do we take sort of cutoffs in terms of the signs and symptoms? And that's been quite poorly done in the past. So I think all of those things will feed into a slightly more robust study designs and better generalizable outcomes in epidemiological studies going forward. So I do think that helps. But I think you still have that problem. You know, I've used an OCI and someone else has used an OSDI. How does that compare in terms of the cutoffs for having the disease or the disease severity.
And when we talk about questionnaires, and that's something I'm always preaching, is using validated surveys in your practice, because it can be challenging to detect who's got dry eye when signs and symptoms don't match. Osmolarity can vary depending on how you capture and when you're capturing. Some of our findings can vary. Techniques and corneal fluorescein staining affect your findings on the slit lamp. So questionnaires, I think, are just a very important place to start with screening. Personally, I'm using OSDI to pull out the visual related quality of life. I've used speed plenty in the past for the sake of speed, because it's pretty fast for patients to fill out and to score. Can you talk some about what you learned about questionnaires, or what the subcommittee came up to about questionnaires?
Yes, and perhaps, some more recent evidence as well, maybe, and that you're absolutely right. I think that it's really important to, and I think that's one of the messages that came out from this study, the importance of questionnaires, not just in the diagnosis and the severity stratification, but just monitoring over time. And one of the things that we also, one of the really key things of this workshop was to involve the patient voice as well. So we certainly had a lot of dry eye patient advocates, and we had somebody who was embedded in our subcommittee, and the opinion from her constituents was very much that they wanted to understand which questionnaires they should be using as patients to be able to self-monitor and take that information to a practitioner. So I think this whole emergence of the kind of online and the apps that let you do the OSDI and other vision-related and symptom-related questionnaires, that's fantastic, because I think people can engage a little bit more. But you're right about practitioners maybe not engaging, and there's been a lot of discussion about this, in that, perhaps the only time that that questionnaires are being used is in clinical studies rather than in general practice. I think that's problematic when you're managing dry eye. So I do think that's, and certainly some of the work that we've done more recently really suggests that the two things that might improve our ability to diagnose and manage dry eyes is using grading scales around things like ocular surface signs, but also using a validated questionnaire regularly. And I think that it's always time that's cited by practitioners, and I think the whole idea of using an app and getting patients to complete these before they come to appointments is something that is, certainly I do all the time now, and I didn't previously, but so that's sort of changed certainly how I approach them.
One of the future directions, speaking of apps and technology, was this idea of using technology to record diaries, which implies kind of daily recording of symptoms and triggers and things like that, and that makes perfect sense. Why not utilize the technology that we carry around with us all day? And yes, the digital OSDI is nice, but it's not really a diary. It makes, I think, convenience for the patients. But since the DEWS 2 was published, are you aware of any movement in that regard? Because I don't know of any diary apps, or I don't think I'm, as a clinician, not instituting technology to its fullest extent. And I wonder if either one of you are.
I think we might be talking about two different things here. And a lot of the questionnaires, if you look at validity of questionnaires like the OSDI, they're looking at a period of time, so they're not really appropriate for daily use.
Right.
There are a couple. We've published on one called the IOS, which is an instant ocular symptoms survey. But again, these have been used from a perspective of more clinical studies or research studies rather than things that are necessarily useful in daily practice. So we've used them to do things like look at the variation in symptoms across a menstrual cycle, for example. So, those kind of research questions. And I see less of a need for the daily measurement, but I do think the sort of periodic, maybe 6 weeks or monthly or something like that, to get a sense of how the disease is tracking over time. So I do think it's chronic, but I'm not sure it's always progressive.
That's interesting. And so Fiona, just for our own edification, so you can educate listeners, tell us a little bit about your career, how you ended up in the research world. And you started out with a bachelor's in optometry from Australia, or England?
No, I'm English. So I trained in the UK, and I did my pre-reg training at Moorfields Eye Hospital in London, and went on to do a master's, and then came back to Moorfields and City University to do a PhD. And that was in contact lens related disease. So again, epidemiology of contact lens related disease, particularly with an interest in corneal infection and microbial complications. So I guess I've always had a sort of interest in keeping the clinical practice going while I was in a research career. So I've endeavoured to do that and probably move more into the kind of dry eye, red eye space as I've moved through my career. So for me, the eye does drive all the research questions, and I'm, really passionate about making contact lens wear safer, but also, improving the lives of people with dry eye. I guess most interestingly, recently, I've probably got more into the kind of neuropathic dry eye. A lot of questions around why this is happening and trying to understand the features and when to intervene and how to intervene in that group, which I think is probably a very poorly served group of patients.
I think the three of us could spend the next few hours talking about the neurosensory component of the lacrimal function unit. No doubt a big interest of mine and Chris's as well. You bring up a couple questions. Risk factors. Contact lens wear as a risk factor for dry. What were some of the takeaways from your subcommittee about that?
Well, it's really quite difficult to tease some of these things out sometimes, because the whole issue with contact lens related dry eye is often that you take the contact lens out and the dry eye goes. So there's a sort of difference there between sort of dry eye and contact lens related dry eye. But clearly contact lens wearers have increased symptomatology, and I think some of the more recent work showing this whole link between contact lens wear and meibomian gland changes, perhaps that picture is beginning to fit in terms of understanding some of the changes that are occurring with contact lens wear.
Well, it's a side question, but I know that it's one of your areas of renown and expertise, but infections with contact lenses. And in particular, lately, these cosmetic contact lenses that are very popular in Asia and Asian countries. What have you learned about those? The contact lenses that color the eye and the contact lenses that make the pupils cat-eyed or larger pupils. I know we all know that the infection risk is higher in those, but what has your research specifically been in around those, and why does that happen?
Oh gosh, how long have we got?
In 5 minutes or less.
So most recently, we've been working with the Asia Cornea Society and looking at a large multi-country infectious keratitis study. And my interest there has been in the sort of contact lens related infections. And I was a little bit surprised looking at that data to find that of the 7,000 cases of infection, about 10% were in contact lens wearers. So I had a group of about 700 wearers, and a third of those were in those sort of coloured or circle decorative lenses, rather than sort of refractive contact lens users. So one of the things that we've done that's just been submitted is trying to look at differences and what were the demographics or other characteristics that were different. And you're right about the risk being higher, but it's an interesting group, and it sort of challenges how we do the studies really, because it's young females, as you expect, that are overrepresented in those groups with infections. In Asia, most of these were old HEMA lenses, so they tended to be lenses that were manufactured with a pigment on the back surface rather than a laminate type lens, which I guess is what we're used to seeing if we're just looking at coloured lenses. People taking longer to seek care because they're not identified with a practitioner, so they get a problem and they take longer to sort of find an eye care practitioner for eye care. So they're an interesting group from a perspective of how do you access that type of a group for education and support and how to communicate with them about where to go if they have a problem. There's also some questions around the sort of sale and supply, because these are old lenses, not old lenses, but old technology that's kind of been grandfathered in a lot of the licensing requirements around the different countries. They are being sold with a license. They're not unlicensed lenses. So the whole sale and supply is an interesting issue. But as is, how do you access a group that are not coming to practitioners for their lens supply in terms of making sure they have the best products and the right education? And I think that's that's a huge challenge. Asia is interesting because the circle lenses are so common. So most of those decorative lenses are the sort of circle lenses to make their eyes look a bit bigger.
You know, Chris and I have spoken about this before, that the contact lens dropout rate's really unchanged over the last 20 years, despite a heavy industry investment. And when I talk to practitioners about this, I'm, in the same way, you can't exercise away a bad diet. I think you need to optimize the surface of the eye and optimize the technology and the design, the modality. Do you think that practitioners lean on the technological advances to overcome problems as opposed to optimizing the eye first?
So, possibly. If I can sit on the fence with that one. So I do think there are several issues wrapped up in what you've said there, Scott. So the whole idea about the numbers of wearers in the community not changing that much, and if you could just reduce the dropout rate, even by 25% or by half, you would really see huge growth in the market. And I think that we understand it's not so much about the best material and the best design from a perspective of certainly teaching and trying to understand where we're at with retaining wearers in wear. I do think it's about optimizing the ocular surface, but I also think it's about managing wearer expectations. And talking to really experienced practitioners, they seem to know who's going to struggle, and they seem to be able to work with managing expectations. So no, perhaps you won't get your 8 hours a day, but you could wear your daily disposables for sport, or and that's going to be a really good outcome for you. That's success. So I think it's about managing expectations as well as optimizing the ocular surface. And I think that what we know about the meibomian glands and what we know about tear film and how the contact lens interacts with the ocular surface, I think optimizing the ocular surface is really important and giving your wonderful technology the best opportunity to provide a good solution for your patients.
In that same vein, I don't know if you know, Dr. Starr here created the Ascaris algorithm for pre-surgical workup for patients. And I'll ask both of you this question. LASIK is a risk factor for dry eye disease. How important, and getting back to your neuropathic pain or neurotrophic keratitis potentially, how important is setting the stage, addressing the ocular surface prior, not only for accurate measurements and good surgical outcomes, but preventing a long-term chronic dry eye patient or potentially a neuropathic pain patient?
Oh, Chris, you should take that one.
Well, it's complicated. And, again, with prevalence and studies, the prevalence rates, I've seen everything from less than 1% in post-LASIK dry eye to 100%. So, again, it comes down to how you measure it, and is it symptomatic? Is it signs? Is it both? But I tell, as my day-to-day practice, I tell every single patient who I'm entertaining laser vision correction on that if they have dry eye prior to the surgery, it has to be treated and essentially reversed prior to doing the surgery, because the surgery will make it worse. Guaranteed. Well, 100%. I don't quote statistics. It's 100%. And if I can't get it under control prior to the surgery, then I don't do the surgery. Plain and simple. It's a contraindication as far as I'm concerned. I usually favor surface ablation over LASIK anyway, and I think that's a little gentler on the nerves and the post-operative neurotropic state and long-term neuropathic, but it's a risk for anybody, whether it's LASIK, PRK, SMILE, or any incisional surgery on the cornea, that there is a risk for worsening dry eyes, but also this neuropathic and or neurotropic states afterwards. Usually the rule of thumb is it's 6 months or so, roughly 6 months, and then it gets back to baseline. But of course, anecdotally, there are patients who have it longer and some patients who don't get drier at all afterwards. So it's all over the place, but I usually prepare for the worst and try to get it under control before doing any surgery. And if I can't, no surgery at all. But interestingly, and it gets back to the contact lens discomfort versus dry eye and contact lenses, and that's what drives a lot of people to have laser vision correction. I can't wear my contacts anymore. My eyes are irritated. I can't. And so it makes things, and a lot of times I will treat the dry eyes and sometimes also have their contact lenses refit or assessed by an optometrist who works in my group. And a lot of times we can get patients comfortable in their contacts, and then I tell them, well, great, don't let's not do laser vision correction. You're comfortable in your contact lenses again. We either refitted and got them, and I'm assuming that's more of a CLD versus we get their dry eye under control, and the same contact lenses that they were wearing are now comfortable versus refitting them and getting them comfortable. And I'm certainly not an expert on contact lens discomfort versus contact lens related dry eye, but my assumption is that is kind of the difference. Contact lens discomfort is contact lens primarily related and due to the contact lens fit or material or what have you. And the dry eye is the dry eye.
And Fiona, the subcommittee mentioned when we talk about risk factors and we talk about people who should practitioners be looking for. We can stereotype postmenopausal women as being the prime target or candidate to suffer from dry eye disease. And in fact, Essenakpak found in her study 26% of patients who were suffering from aqueous insufficient dry eye or MGD actually had rheumatic factors or Sjogren's, correct?
Yeah, I think that's true. I'll go back to my sort of population-based measures, though. I think the proportion that have the rheumatic factors or the Sjogren's are a small proportion that fit into that severe group. But you are right, and I think all the population-based studies that have looked at risk factors would confirm that those two groups as being at a much higher risk. So I think we all jump to that very quickly, but I think there are some other questions that need to be addressed, and I think the youth side of things is really quite important, and certainly some studies that have been published since the DEWS 2 report are looking particularly at youth and at digital device use, which I think is really quite important. And I'm talking about Australia here, but looking at things like climate and looking at environmental factors like the bushfires, we had a huge uptick in our dry eye clinic after that period. So there are other local factors also, which I think are interesting to look at. But the youth and the digital device use, I think, is really interesting because there's been so few studies in children that we don't quite understand where that's sitting at the moment.
Was there a particular study that you latched onto about younger people suffering from dry eye disease?
So the two that were in the paper were from Asia, but that, as I say, that's been sort of replicated since the publication of this report, which, again, looking at high school students, and you mentioned the study that's looked at the Moon study that's looked at the younger children as well.
Have there been any studies that tie digital use, dry eye in young kids and myopia? Since they're indoors more and possibly becoming myopic and dry?
There's not great quality of evidence around that at this point, but yes, you'd think that was all, kind of wrapped in together, wouldn't you? And the things that I've been trying to dig into are some of the myopia control studies. So I'm working with a group in China that's doing quite a lot of the myopia control large-scale studies, and I'm trying to sort of dig out the sort of symptomatology side within that and the digital device use and the hours of outdoor time. So I think we just don't have the really nailed-on evidence at this point.
One of the things that your subcommittee took on that I was surprised to find part of your subcommittee were the economic and quality of life burden that patients and our societies suffer as a result of dry eye disease. Any surprises in there for you?
Only from a point of view about the magnitude of the impact, I think. I think that we see our sort of dry eye patients and they're, uncomfortable and unhappy. But in terms of the societal impact and the amount of time people are taking off work, I think to deal with either not being able to work or trying to deal with the sequelae and the appointments and everything else. So I think, using up most of your sick leave on dry eye, thinking about it in those terms and reduce productivity at work. So I think the magnitude surprised me more than the individual components of that.
What do you for our listeners today who are seeing patients in practice, what do you think are the most significant risk factors? Do you have a ranking of the top 5 risk factors to be a dry eye sufferer?
So the way we endeavoured to do this, and this wasn't my idea, this was something that had come from the previous sort of iteration of the DEWS report, was to try and split risk factors into sort of, consistent, probable and possible based on the level of evidence. And what we tried to do kind of beyond that was to split in terms of modifiable and non-modifiable, with a thought that maybe the non-modifiables help you with understanding the things that you can address. So, we've talked about age, we've talked about sex, we've talked about race, we've talked about, the diabetes being in that kind of probable factor, we've talked about androgen deficiency, Sjogren's, rheumatic, and so on. But some of those other factors that we start to understand that have come out of the modifiable, perhaps around things like environment, screen use, I think that's been consistently identified. And I guess some of the things that we know, we understand the refractive surgery and the iatrogenic dry eye, and trying to address any ocular surface issues prior to surgery. So I think those would be the way that I would interpret that kind of analysis of the risk factors, and maybe trying to look at that through a lens of a kind of local or practice type environment.
Were systemic medications or topical medications something that you looked at?
So in that study, there was certainly some work on glaucoma medications, perhaps as you might expect. Again, not vast amounts of randomized controlled trials on that, but certainly emerging as a risk factor. And I think we understand very well things like the depression medications, having depression and the medications themselves. The other thing that was kind of interesting about beta blockers, topical beta blockers, and again, obviously linked with glaucoma treatment, but in the one study that's looked at natural history, and this was using medical records from the US, published in 2016, but they looked at factors which were associated with progression of the disease, so worsening of the disease. And certainly topical beta blockers in that study were very strongly associated with worsening of the disease, as was having MGD at the start or having more severe disease at presentation. So I think we can start to pick things that are associated with the disease per se, and perhaps risk factors that are associated with progression of the disease. So certainly the beta blockers there were very strongly associated.
So what also caught my attention about what you're talking about is related to vision and social impact. MGD or blepharitis was linked to that same thing. How are you describing posterior blepharitis, same as MGD, or were you talking about anterior collarettes and all of how were you?
So in that study, this is the LINET study, the strongest association was with MGD. There was a weaker association with blepharitis, which they didn't actually split, but I kind of had in my mind that they probably meant anterior blepharitis in that study.
Yeah, your subcommittee probably didn't do a deep dive on the BAK and the topical and systemic medications because you knew the iatrogenic committee was doing all that. Yeah. One of the fascinating things I remember from your report was the fact that virtually all the big prevalence studies were done in the northern hemisphere, and basically Europe, Asia, and the US. Yeah. And that there were really no studies, zero, in the 10 years between DEWS 1 and TFOS DEWS 2 from the southern hemisphere. And I guess my question is, why is that? Obviously there's dry eye there, I would assume. And maybe the warmer, all the humidity and the warm temperatures, maybe there isn't. But, or there's a lack of interest in dry eye amongst clinicians who would otherwise be studying this, or is it a combination of a lot of things?
I think it's a combination of a lot of things. I think those... a lot of the data from the US and Europe has come from large registries, which don't exist in the same way. But it's interesting, since the report, while we were putting this together, a lot of those subcommittee members have disappeared off and done some really nice studies. There's been a lot now in South America, some very nice ones in Brazil, looking at different populations in the kind of rural and remote regions versus the urban areas. And that, again, is sort of confirming those differences in lifestyle and risk factors between those groups. And there's been a couple of studies now that have been published from Africa and a few more in Scandinavia. So there's a few more kind of popping up. In New Zealand, there's been a couple of prevalent studies and a study on 45-year-olds looking at a large cohort. So pulling those data out from I guess, applying questionnaires in existing registries and things like that. So I think that, certainly 2018, 2019, 2020, we're seeing more of those population-based studies now, including dry eye signs and symptoms in those registries. So we've just got one. We have a national eye health survey in Australia, which didn't include dry eye historically, and now we've got dry eye, both signs and symptoms included in that study. So I think that the greater awareness and the push from practitioners to get that information relevant to their jurisdiction, I think, has driven that since the report.
And I wanted to clarify also, when you mentioned that being Asian appears to be a risk factor for suffering from dry eye, does that mean being born and raised and living in Asia, or does that apply to an Asian population in other countries?
Yeah, it's interesting. There's only a couple of studies that have tried to sort of dissociate that, and the findings have been a bit equivocal. So most of the studies that have made that comparison, so obviously the first comparisons were studies done in Europe versus studies done in Asian countries, and there's been a couple now that have looked at differences, and we've got a couple in Australia now that have used Southeast Asians living in Australia and shown again that they have a higher risk than Caucasian people living in Australia. So I think there may be some genetic and some environment components to all of that. I don't think it's an either or, but we do see that change in people who are living in other climates.
One of the things that we like to do is, this is a translational medicine podcast, Fiona. So what we're trying to do essentially is highlight marking the 3-year anniversary of TFOS DEWS 2. A lot of doctors are still looking for, how do I look for it? How do I treat it? How do I diagnose it? And not really recognizing that TFOS DEWS 2 has all of that information in there with several subcommittees. And it's sort of like, how do you eat an elephant one bite at a time, and getting through the subcommittee. Very, very interesting to me. Some of my takeaways, and so my point being, we like to provide clinical takeaways for our listeners. What can they take from the findings of your subcommittee to apply into practice? And I'll give you my takeaway is using validated questionnaires and giving them to everybody, because we're really looking at risk factors that range from young kids all the way into older, all throughout lifetime, based on different risk factors, some modifiable, some not. So screen everybody with a validated questionnaire in your practice. That would be my takeaway. Chris, anything from you?
Well, I think with epidemiology, I'd like to see in TFOS DEWS 3, 10 years from now or 7 years from now, more of the prevalence studies being based on objective data. I think that makes a lot of sense, because a lot of the problems in the past are the subjective nature of dry eye. And if you look at certainly the definition was important at homogenizing that message, but I do think that if you look at the diagnostic methodology section 2, where they walk you through the sort of algorithm of the TFOS recommended algorithm for diagnosis. So that's the OSDI and the DEQ5 questionnaires, and then osmolarity, non-invasive tear breakup time if you don't have the machine, and staining. And I think that if the world kind of at least took that to heart and started doing studies with that definition and that diagnostic methodology and that objective data in mind, then I think that we could have better prevalence data going forward. It's not perfect, the machines and the object, like you said, osmolarity can vary, but it's better than, I think, just a symptom prevalence study.
And how about you, Fiona? What would you like to know, practitioners to know, either from your independent research or based on TFOS DEWS 2 subcommittee and epidemiology? What would you like practitioners to know that they might not know?
I think what you said about the questionnaires is absolutely bang on the money there. I think that the only way we know whether the disease is changing is by measuring, rather than just saying, how do you feel today? I think those kind of the way we've been doing that doesn't cut it for helping our patients in terms of understanding the history of the disease and whether our treatment's working. I think everything you've said about diagnostic methodology is really important. Practitioners tend not to use grading scales around this staining. So again, what's grade 1? Do we know that this is changing? Have we got severe staining? Where was it on the cornea? Those kind of things that will help us, again, track the management. I think the other thing is, in that whole triaging for dry eye, understanding the risk factors and making sure that the questions are appropriate to that. I think that probably helps with understanding people's risk for dry eye versus, other ocular surface disease. And I suspect the other, and again, this is not so much around the epidemiology report, but ruling out everything else, making sure that you manage the ocular allergy and everything else is so that you know that you're actually looking at and treating dry eye.
One last question I have for you, Fiona. You played a role in the definition and classification committee. Were you satisfied with the ultimate definition? Is there anything you would change about it?
It's really hard, isn't it? Doing anything by committee is a tricky process, but that's the goal of consensus. So it is very hard. But I think that was a really good compromise because it captured the recent evidence, the fact that there's inflammation is important. It also captured the symptoms, including both vision and discomfort symptoms, and the whole neurosensory aspect, which I think we hadn't really understood well before. And I think that whole area is just incredibly important to understand and to really get at the nociceptive pain versus the neuropathic pain. So I think that for me was another really important aspect. And I did mention this, but I think having the patient perspective in that workshop was really invaluable.
Agreed. Was quality of life impact on quality of life ever part of the discussion as being part of the definition?
It was, but it didn't sort of reach to the, I guess that's a much harder thing to put into a definition, whether you're talking about a disease definition or whether you're talking about using it to measure prevalence, talking about the impact on the patient. But it was certainly something that they were very keen to have addressed as part of the whole workshop. Anything else, Chris?
No, I think this is great, and I realize I've said the word homogenize many times in this discussion, and I realized after the fact that the actual operative word of the TFOS DEWS 2 is harmonization, right? Harmonizing all the various subcommittees and not having conflicting information, but also not having too much redundant information amongst them. So, like with the iatrogenic stuff, that was covered in the iatrogenic committee rather than in your prevalence, although you did touch upon it. But I think a better word than homogenize is harmonize. So we can harmonize the world when it comes to future studies on prevalence, and we can all be in harmony with our data.
Very good. Well, Fiona, thank you so much for your time today. We really appreciate it. I know you're busy. You're doing a lot of research and you're doing a lot of work. Keep up the good work. And we look forward to your next set of research from you.
Oh, thank you so much. It's an absolute pleasure. And I'm so very humbling to be asked to do this kind of thing. So thank you very much.
Thank you.
Thank you.
Thanks for listening. Join us for our next episode soon. Find us online at www.ocularsurfaceacademy.com, all major podcast platforms, and YouTube.